Welcome back to the module on acute pancreatitis. Here we are going to discuss the etiology, clinical features, and how to manage a case of acute pancreatitis in toto. Right. Let us begin our topic with the etiology of acute pancreatitis. Coming to the etiology, first I want to mention the three major causes of acute pancreatitis. After that, we are going to see the other causes. Okay. The most important are first three causes, and remaining for your exam you have to remember some of the causes. Okay, now what are the three most important causes of acute pancreatitis? Can you guess? Alcohol, yes, good. Any other? Gallstones, yes. Now the first one is gallstones. Very important one is gallstones. Even much before alcohol, I want to mention gallstones. After that only I want to mention alcohol. After that I want to mention post ERCP. Means I have done ERCP in a patient. After that ERCP, patient get a complication of acute pancreatitis. That is post ERCP. Now gallstones alone, 50 to 70% of the cases of acute pancreatitis are due to gallstones. Approximately 25% of the cases of acute pancreatitis are due to what? Alcohol. Right. These are the three main causes which you should never forget. Okay. Now coming to the other causes of acute pancreatitis. Any trauma to the abdomen, abdominal trauma can cause acute pancreatitis. Any usage of drugs. Sir, which drugs? Means steroids can cause. Valproate can cause. And azathioprine. There are many drugs, but I am listing few here. Now, few conditions. Hyperparathyroidism can cause this. Hypercalcemia can cause this. Hypertriglyceridemia. Okay, these are the few. And pancreatic divisum, which you are going to study in the anatomy also. Pancreatic divisum, acute pancreatitis. Sphincter of Oddi dysfunction. Okay, now autoimmune pancreatitis, hereditary pancreatitis, autoimmune pancreatitis, hereditary pancreatitis, and some viral infections. So which viral infections can cause this? One is mumps and the other is Coxsackie B virus can cause this. Now, even sometimes post-operative patient can also develop acute pancreatitis. After which surgery there is risk of acute pancreatitis? Upper GI surgery or a cardiothoracic surgery can lead to acute pancreatitis. Write it down. Post-operative patient after upper GI surgery or a cardiothoracic surgery. And you already know idiopathic can also be the cause. So let us look into the etiology again. Three main causes are gallstones, alcohol, post-ERCP, and the other causes being hyperparathyroidism, hypercalcemia, hypertriglyceridemia, hereditary pancreatitis, autoimmune pancreatitis, idiopathic pancreatitis, post-operative patient upper GI surgery or a cardiothoracic surgery patient can also we can see. Okay, And abdominal trauma and drugs, you already know which drugs: steroids, azathioprine, valproate, right? Other things you can remember. Coming to, I would like to somewhat expand the first three causes, right? Gallstones, alcohol, and post ERCP. Coming to the gallstones, sir, the question is why the gallstones are going to cause acute pancreatitis? How they are going to cause? Now let us take green. Where is this green? Just wait a second. Yes. Suppose this is my gallbladder, and the gallbladder there will be a cystic duct. This is your common hepatic duct to form the common bile duct. Right. This is your common bile duct, assume. And this is your pancreatic duct. Your common bile duct and pancreatic duct are opening where? Into the second part of the duodenum. Okay. Right. The stone which has formed within the gallbladder it is now coming down. When it comes down, and when it is going to block this channel, what happens? There will be reflux. Okay. So the pancreatic enzymes which are coming through the pancreatic duct, they are going to get refluxed due to the presence of this stone. Now what happens is, these pancreatic enzymes are going to they are going to enter where? Again they are going to enter the pancreas only. So due to the presence of activated enzymes within the pancreas, now what is going to happen? There will be irritation which is happening within the pancreas. There will be acute pancreatitis. Now we will write it down. So what is the trigger factor? So this is going to be triggered by passage of the gallstones down the CBD. Okay, down the CBD. So there is something like reflux of bile bar pancreatic enzymes into the pancreatic duct. So the presence of activated enzymes within the pancreas is going to cause what? Pancreatitis. Right? Now coming to the alcohol. Why alcoholic patients are at risk of developing pancreatitis? Tell me. Why? First thing is their diet is going to be impaired. Second thing is they are somewhat in a malnourished state. Even the direct toxicity of the alcohol can also cause this acute pancreatitis. And some of the alcoholics are also smoking also. That is why concomitant tobacco smoking is also a risk factor for this. And in alcoholic patients there may be hypersecretion of the pancreatic enzymes or bile, and there can be duct obstruction, and even hyperlipidemia is also a risk factor to develop the pancreatitis. So these are the various factors which you can tell that alcoholic patient is going to develop acute pancreatitis. Diet is there, malnutrition is already there, and hypersecretion will be there, duct obstruction will be there, hyperlipidemia will be there, direct toxicity of alcohol will be there. Yes, these are all the factors. Now coming to the ERCP. Right. Now coming to ERCP. So among patients who has underwent ERCP, how many persons are usually developing pancreatitis? Only 1 to 3% of the cases are going to develop acute pancreatitis. Okay. Now coming to we have seen the three major causes, and now we are coming to the clinical features of acute pancreatitis. Acute pancreatitis is everything about pain, 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 pain. So the patient is going to present to you with pain. Clinical features entirely it is pain, pain, pain. Now let us look into it. Clinical features is pain. Pain is a severe kind of pain, that to a constant pain. It is not an intermittent pain, it is a constant pain. And even if you give some analgesics, it is refractory to the usual dose of analgesics. So the pain in pancreatitis is going to be severe. It is going to be a constant one, and even if it is refractory to the usual dosage of the analgesics. The most important feature of the pain in pancreatitis is, first it is going to start in the epigastric region and it is going to radiate to the back. Any pain which is starting in the epigastric region and going towards the back, always think in terms of acute pancreatitis. And one more thing is, when you bend down, on bending forward, the pain is going to be relieved. Any MC or any question mentioning this, pain in the epigastric region radiating to the back decreases on bending forward, always think in terms of acute pancreatitis. Right? Write it down. First in the epigastric region, after that it is radiating to the back. But one more thing I want to tell you, which is going to be relieved on bending forward. This is classical of acute pancreatitis. Sometimes you can see a similar picture in perforated peptic ulcer disease. There also you can see pain first in the epigastric region, after that it is radiating to the back. Similar kind of picture you can see if it is a perforated case of peptic ulcer disease. Now, so first feature we have discussed is pain. And what are the other features? The patient may have nausea, the patient may have vomiting also. These are also clinical features of pancreatitis. Now, hiccups may also be there. Two important signs I want to mention in this acute pancreatitis, without which we cannot complete the clinical features. One is Gray Turner sign. And the other one is Cullen's sign. So what is the Gray Turner sign? There will be bluish discoloration of the flanks. On the flanks there is bluish discoloration. Please write it down. Bluish discoloration of the flanks is called as Gray Turner sign. If it is in the flanks, then it is called as Gray Turner sign. What if it is in the center? Then it is called as Cullen's sign. If it is in the umbilicus area, then I have to call it as a Cullen's sign. Okay. Now, on examination, what I can find? There will be abdominal distension will be there. Okay. And you can see guarding rigidity like them also. You can see. Now, what are all the investigations I have to do in case of acute pancreatitis? Please make a note of this. Serum amylase, serum lipase are the first investigations I am going to do in case of acute pancreatitis. Write it down. serum amylase and serum lipase. So serum, if there is increase in these enzymes by 3 to 5 times, then I am going to suspect pancreatitis. And one more thing I want to mention, coming to serum amylase. Amylase is something which is present due to various other things also. That is why it is completely a non-specific entity. But if you ask me the lipase is the one which is somewhat more specific, and it is something which is more sensitive also. So, but we are measuring both serum amylase and serum lipase, which are going to increase by 3 to 5 times. Serum amylase being the one which is non-specific, serum lipase being the one which is specific and which is sensitive also. Presence of normal levels of these enzymes does not exclude pancreatitis. Please remember, even there can be normal levels of these enzymes also. And one more thing I want to mention is, serum amylase and serum lipase levels are not going to tell me the severity. Means if they are increased by 5 times, if it is increased by 10 times, then the severity is much more like that. There is nothing like that. They are not going to tell me the severity. Okay, nothing to do with the severity. Coming to the next one, we have seen the serum amylase and serum lipase. Coming to the other investigations which we are going to do in case of acute pancreatitis. So next one is X-ray. Under X-ray there are few signs you have to remember. Okay, directly remember the signs. Do not go into depth why, what is that actual sign and all. Just remember the names and move ahead. So on X-ray you can see something like a gasless abdomen you can see in pancreatitis. Okay, now next you can see a sign, sentinel loop sign, colon cut off sign, and renal halo sign. These are the various signs which are seen on an X-ray in case of acute pancreatitis. What are they? Renal halo sign, sentinel loop sign, colon cut off sign. Okay, gasless abdomen. These are the various features you are going to see in case of X-ray. Now, how to assess the severity in case of pancreatitis? There are many scoring systems in acute pancreatitis. Just it's always better to remember the names, but going into depth of each and every severity score is not required at your level. Okay, now two important scoring systems are, one Ranson scoring system and the other is Glasgow scoring system. These are two most important ones. So any score, if the score is 3 or more, any score of 3 or more indicates that it is a severe attack. So any score of 3 or more in a Ranson score or in a Glasgow score, if the score is 3 or more, it indicates that it is a severe attack of pancreatitis. Now, not only Ranson and Glasgow, there are many others also. Let us enlist the others. Let us try to enlist the others. Modified Atlanta score, Apache 2 score, BISAP score. Even I can use a C-reactive protein to assess the severity. So Ranson score and Glasgow score, I want you to remember. Score of more than 3, acute pancreatitis is severe. Other scoring systems are modified Atlanta score, Apache 2 score, BISAP score, C-reactive protein. These are the various entities I can use. Now coming to chest X-ray. I have told you the features on abdominal X-ray. Now coming to the chest X-ray. Why I am performing this? So that they are going to be useful in differential diagnosis. Even I can rule out other causes also. Suppose I am thinking in due to that severity of pain abdomen, I can think in terms of intestinal obstruction. So I can get understanding that in a X-ray. So useful in differential diagnosis. That is why I am going to get a chest X-ray and a X-ray abdomen done. Okay. Now, what is the use of ultrasound in this patient? Ultrasound may tell me the presence of gallstones. Ultrasound is helpful. Now, there is a criteria to tell acute pancreatitis, that is called as Balthazar criteria for acute pancreatitis on CT scan. Okay, just to remember the name, that's it. Now, should I perform CECT in each and every case? Should I perform CECT in each and every case means the answer is no. There are specific indications where I have to get a CECT done. Now tell me what are all those. If I am of diagnostic uncertainty means I am unable to confirm whether it is due to pancreatitis or due to some other cause also. I am in a diagnostic uncertainty. I have to get a CECT scan done. Now second thing, in patient with severe acute pancreatitis, to distinguish from necrotizing pancreatitis, very important. So to distinguish severe acute pancreatitis from a necrotizing pancreatitis, I have to get a CECT scan done. But one thing I want to mention over here, in the first 72 hours, CT may underestimate the extent of necrosis. Very important point. So if at all I have to do a CT scan to differentiate between severe acute pancreatitis and a necrotizing pancreatitis, I have to do it after 72 hours only. Why? Because the extent of necrosis is underestimated if I perform before 72 hours. That is why CECT is always recommended after 72 hours, so that necrosis also we can estimate ideally. Now what is the other indication? When a local complication is suspected, what are all the local complications we will come to later? Something like peripancreatic fluid collection is there, pseudocyst formation is there, or pancreatic ascites is there, any other thing is there. To diagnose that, I can get a CECT scan done. Okay, when I am in a diagnostic uncertainty, when it is a case of when I want to distinguish between whether it is a severe acute pancreatitis or necrotizing pancreatitis, and the third one is when I suspect a local complication. To diagnose that, I can take help of a CECT. Moving ahead. So how to manage this case? How to manage the case of acute pancreatitis? Means treatment we are coming. We have already seen the investigations. Coming to the treatment. First one is IV fluids is part and parcel of pancreatitis treatment. In fact, the most important treatment, if you ask me, without any doubt, I would like to answer it as IV fluids. Okay, IV fluids I have to give. Not only that, I have to monitor the vitals of the patient. I have to monitor the urine output of the patient. And I have to monitor the central venous pressure also. Okay. Now, I ask the patient nil per oral, not to take anything through the mouth. Now, whether antibiotics are to be given or not means what some textbooks recommend is there is no role of antibiotics in acute pancreatitis. So antibiotics are not recommended. Please write it down. Antibiotics are not recommended in acute pancreatitis. When to indicate we will come to, but in general they are not indicated. Analgesics are very important as well. Why? Because for the pain relief, analgesics are a must. Now, I have already told you patient may present with nausea and vomiting all. So antiemetics are also the part of the treatment. Okay, IV fluids, nil per oral. Antibiotics may not be recommended. Analgesics are part and parcel. Antiemetics are part and parcel of the treatment. Now I have to treat based on the severity of pancreatitis. If it is a mild case, how to decide the severity? I have already told you various criteria: Ranson, Glasgow, modified Atlanta, Apache 2, Bicep, all those things. And I'm going to divide whether it is a mild case or it is a moderate or a severe case. If it is a mild case, then on ultrasound, if it showed me, I have already performed ultrasound, right? If it shows me the presence of gallstones, or gallstones may be there or may not be there on ultrasound. If it is due to gallstones, I have to do laparoscopic cholecystectomy. In the same admission itself, I have to perform laparoscopic cholecystectomy. If it is not due to gallstones and it is a mild case, then I have to avoid the inciting factor. Okay. Now, if it is a moderate or a severe case of pancreatitis, then also I am going to get an ultrasound. It may or may not show me the presence of gallstones. It doesn't matter. My treatment is I have to insert a central line. I have to give a total parenteral nutrition, central line. Supportive treatment I am going to give to the patient. Total parenteral nutrition I am going to give. And now the moment I can hear the bowel sounds, then I can change the patient to Ryle's tube feeding. Okay. So like this I am going to continue the supportive treatment with IV fluids, analgesics, antibiotics, all those things I am going to give. Now, after 24 to 48 hours, what is the position of the patient? So he is improving, that's fine. Or check whether he is not improving. The moment patient is improving, continue the treatment for another 24, for almost 6 to 7 days you have to continue the same treatment. After that I have to get a CT scan done to look whether there are any local complications. If the patient is not improving, check whether it is due to we already know we have already performed ultrasound here in the presence or absence of the gallstones. So if it is due to gallstones, what I will do? If it is due to gallstones, then already the patient is in moderate or severe pancreatitis and it is not improving also now, and the cause is due to gallstones. I have to do what? I have to do endoscopic sphincterotomy and I have to remove all those gallstones. If the gallstones is not the cause, then after 48 to 72 hours I have to get a CT scan done. CT scan may show me there is a necrosis. How to tell there is necrosis? There will be gas bubble. Okay, gas bubble in CT. So due to necrosis, if it is due to this necrosis, this is the time. Just wait a second. Okay, this is not working. Just okay. Now if it is due to necrosis, what happens? I have to start systemic antibiotics. After starting systemic antibiotics, if the patient is healing, that's fine. Even if this is also not working, then I have to go for a CT guided aspiration I have to do. I mean percutaneous CT guided percutaneous drain I have to insert. Even if this is also fails, then what is my last step? I have to go for surgery, that is necrosectomy. Okay. Plus I have to insert a feeding jejunostomy also. Coming to the complications. Complications, I am going to divide it into two things. One is the local complications and the other is systemic complications. Coming to the systemic complications, you can easily guess all the systemic complications. What are they? There can be systemic inflammatory response syndrome, SIRS. There can be sepsis. There can be shock. There can be acute respiratory distress syndrome. There can be congestive heart failure. There can be multi-organ dysfunction syndrome. All these things are systemic complications. Now coming to the local complications which can be there. Local complications are peripancreatic fluid collection, peripancreatic fluid collection, pancreatic ascites. Now, pseudocyst of the pancreas, very very important. Pseudocyst of the pancreas. Now, pseudoaneurysm, especially of the splenic artery. Okay. Or there can be pleural effusion. These are the various complications. There are many, but we are limiting ours to this only. So what we have seen so far in acute pancreatitis. So we have seen the etiology of acute pancreatitis due to gallstones, due to alcohol and due to post-ERCP. What are the various other causes? Due to drugs, valproic acid is there, or azathioprine is there, or steroids is there, abdominal trauma, hereditary pancreatitis, autoimmune pancreatitis, hyperparathyroidism, hypercalcemia, hypertriglyceridemia, idiopathic, post-operative patient, upper GI surgery, cardiothoracic surgery. So these are all the various causes of acute pancreatitis, of which we have seen gallstones, alcohol and post-ERCP being the main causes. We have highlighted them. Now coming to the clinical features. Clinical features, it is all about pain. Severe in nature, constant in nature, not responding to the usual doses of analgesics. Now, pain which is starting in the epigastric region and it is going to radiation to the back, which is relieved on bending forward. Other clinical features are nausea, vomiting may be there, hiccups may be there. Two signs, Great Turner sign which is in the flanks, Cullen's sign which has to be in the center, that is the umbilicus. On examination you can see distension, you can see gouging and rigidity, all those things. Now after that, what are all the investigations we have to perform? We have to get an ultrasound done which may tell us presence or absence of gallstones. We have to get an X-ray done. Various signs we have seen, gasless abdomen, sentinel loop sign, colon cutoff sign and renal halo sign. So other investigations also we can do, like we can get a CT scan done or we can get a CECT also. And few other things we have mentioned. X-ray abdomen and chest X-ray are used for differential diagnosis also. Now, what are the indications of CECT we have seen? When it is of diagnostic uncertainty or whether there is a severe acute pancreatitis, and I have to distinguish it from the necrotizing pancreatitis. Kind attention only after 72 hours. And other indication being whenever I am going to suspect a local complication. Now, how to treat a case of acute pancreatitis? Most important is IV fluids and the most important other thing is analgesics. IV fluids I have to give and I have to monitor the vitals, I have to monitor the central venous pressure and I have to monitor the urine output also. Now, antibiotics, still a question mark, not routinely recommended. And analgesics and antiemetics part and parcel. Coming to the severity, it may be a mild case or moderate or a severe case. If it is a mild case, if it is due to gallstones, I have to get the laparoscopic cholecystectomy in the same admission. If it is not due to gallstones, I have to avoid the inciting factor. If it is due to alcohol, I have to avoid the alcohol in the patient. Now coming to the moderate or severe. Moderate or severe, I have to continue the conservative treatment or supportive treatment, I have to continue. And total parenteral nutrition. If the bowel signs are positive, I can change for a Riles tube feeding. After doing all these things, after 24 to 48 hours, if they check whether the patient is improving or not, if at all the patient is on the improving side, continue the same treatment for 6 to 7 days, after which I have to get a CT scan done to assess for any local complications which are formed in the patient. If the patient on the other side, patient is not improving side, if it is due to gallstones, I have to get an endoscopic sphincterotomy done. If it is not due to gallstones, what should I do? I have to check on the CT whether there is any necrosis is there. If there is presence of necrosis, then I have to go for systemic antibiotics. If systemic antibiotics also cannot stop the case, then what should I do? I have to get a CT guided percutaneous drainage done. If it also fails, then the last option I have is necrosectomy plus a feeding jejunostomy done. Okay, when to give antibiotics I have clearly mentioned. If at all there is necrosis and if at all there is necrosis, then I have to start the patient on antibiotics. Or if the patient is on the sepsis side, okay, then also I have to start the antibiotics. Otherwise, routinely not indicated in acute pancreatitis. Now coming to the local complications and systemic complications. Local complications being the most important is pseudocyst formation, others being the pseudoaneurysm is there, or peripancreatic fluid collection is there. These are all the local complications. Even pleural effusion can also be a local complication. Coming to the systemic complication, systemic inflammatory response syndrome can occur, shock can occur, sepsis can occur, ARDS can occur, congestive heart failure can occur, and even what is that? Multi-organ dysfunction syndrome can also occur. This is all about acute pancreatitis in toto. Yeah, thank you for watching.